So I hope we we are ready to go for our discussion of, or basically retrospective discussion of congenital lesions of larynx. So in recent year, I have seen that this topic is getting more and more questions in your exams. So be it a image based question, be it a theoretical question, they are focusing more on these congenital lesions like laryngomalacia, vocal cord palsy, subglottic stenosis, laryngeal web. One part of question is they will ask you about the diagnosis by some laryngoscopic picture. So they will give you some picture of the direct laryngoscopy or indirect laryngoscopy, and they would want you to know whether you know the diagnosis or not, or they will want you to tell what is the management of the condition. So I'm just sending the link to my broadcast group. So if you are not in my broadcast group, you can just ping me at my WhatsApp number. It is readily given in my this YouTube channel, so that whenever I get live, or I teach at Unacademy also, so you can get a notification. And whenever I get time, I also keep on sending some important things so that you keep your track on. So your exams are approaching and you must be in your revision phase. So this revision phase is important for you, because once you have completed everything, now you know the most of the part of your syllabus, but whatever you revise now will boost your memory so that you will be able to recall everything in your exam. So do give importance to your revision and don't take it for granted. Don't take it for granted, by which what I mean is, don't take things that you know this and you will be remembering this. Try to just read it once more. So many a time we take things granted that we have read this subject, so this subject is okay, but with time you might be missing some of the important things from that subject. So you need to revise everything again, but this time your speed should be faster enough. You should be more aligned to the things. So just whenever you read, try to understand things now. So try to understand things rather than just mugging it up, right? Because whenever they will ask question, they will ask it with some application. They are not asking direct question, they are asking some application of the things. So for applying things, you need to emphasize on this part. That means you need to understand whatever you are reading, and this is the way that you will remember things for longer duration, right? Now let us see some common pictures that you can expect in your exam, and then all the possible question that surrounds it. So it will be a short session now. The longer one I will try to make it in your some Unacademy app, because I planned it today, but somehow uh, some sort of problem occurred. So I am doing it live. Okay. So you meanwhile you can just tell me in the comment section ki what condition you can see and what is the diagnosis you can get from this image. Yes, I can see the comments. So it is your omega shaped glottis, which is already written here, and the diagnosis is laryngomalacia, right? Why laryngomalacia is common? Because you all know it is the most common benign condition or the congenital anomaly which is seen here, right? So which causes stridor in infants, most common congenital condition which causes stridor. So once we identify the images, and then we will go to each of them in detail. Can you identify this picture of this laryngeal inlet showing you the vocal cords and something else? So this is your, because here should be your true vocal cords with some space, but here you can see some membrane which is obscuring this space. So it is your laryngeal web, or more particular if you are, it is the glottic web. So first identify the images and then we'll deep dive into it. Here you can see a trumpet blower who complains of swelling which is compressible in nature. Means when he blows the trumpet, this swelling increases, and when he stops, this swelling reduces. So what it can be, right? So this can be your laryngocele. So here the diagnosis with this image is laryngocele. Here again you can see a person with a laryngocele, his X-ray and a CT scan with air filled space, right? So laryngocele is a bulge in the saccule region of the larynx, which is caused due to increased intraluminal pressure. So here again you can see the internal picture where you can see the bulge inside the larynx. So the diagnosis here is again laryngocele. Now this is another picture which will be given to you with a clinical condition like the infant or the child presented to you with a stridor, okay, and on this endoscopy, on the laryngoscopy, you found that there is partial obscuring of the subglottis lumen. So below the vocal cords you can see some sort of obstruction. So this is, the diagnosis is subglottic stenosis, and to grade this subglottic stenosis there is one classification. So if I see the comment section, I want to know how many of you know the name of that classification. Yes, if you know the name, I would be glad enough that you know this. So I'm seeing the comment section who writes me the name of the classification. Anybody? So it's Mayor Cotton classification for subglottic stenosis. So if we see, we have different grades of stenosis: grade 1, grade 2, grade 3 and grade 4, depending upon how much lumen is left or how much lumen is stenosed. So in grade 1 there is 0 to 50% of stenosis, means 50% of the lumen is obscured by the stenosis. In grade 2 there is 51 to 70% of the lumen stenosed. In grade 3 it is more severe, and here the stenosis is 71 to 99%, right? Now in grade 4 there is almost 100% stenosis. So why this gradation is important? This gradation is important because the treatment or the management of this subglottic stenosis is depending upon these gradation. The grade 1 and 2 you can treat by anybody who have idea of this stenosis treatment. So usually the grade 1 and 2 who are asymptomatic or with minimal symptoms, you can go for a conservative approach. But if these are symptomatic and in grade 3 and 4 you have to do something to relieve the patient of the respiratory distress that person is having, then you have to either do laryngotracheal reconstruction, laryngotracheal, I don't know, yeah, laryngotracheal reconstruction, or or resection and anastomosis. Means you will resect that stenotic segment and again do the anastomosis. So it will depend what mode of treatment you choose. In laryngotracheal reconstruction, what you do is you split the cricoid cartilage both anteriorly and posteriorly and place an implant so as to widen the lumen. In resection and anastomosis, you resect that subglottic stenotic segment and then re-anastomose it. So important for you is to remember this Mayer-Cotton grading system, where grade 1, 2, 3, 4 depending upon the management and the area of stenosis you can have question in your exam. So grade 1 and 2 asymptomatic, either you can follow a conservative approach or here you can use some lasers. So like CO2 laser or endoscopic dilatations you can do for grade 1 and 2, CO2 laser or endoscopic dilatation. But in grade 3 and 4, you need to do some surgical intervention like laryngotracheal reconstruction or resection and anastomosis. So there was one question with subglottic stenosis giving you a clinical scenario of stridor, and on examination you found grade 3 stenosis, subglottic stenosis. So the management there was in the option, it was resection and anastomosis. So if you get this type of picture where below the vocal cord you are getting narrowing of lumen, you can go for the diagnosis of subglottic stenosis, right? And why it occurs? This subglottic stenosis usually occur due to iatrogenic trauma, means basically not iatrogenic but you can say intubation trauma. So once the baby is intubated or person is intubated, this intubation induced trauma might lead to your subglottic stenosis, right? And also it can occur congenitally. So congenitally, if we see, this is the third most common congenital disorder causing stridor. The first most common was laryngomalacia, right? So these were some important points, and when you are going to say that this stenosis is present in the subglottis, so there is some dimension also they can ask you in the exam, is when you are going to say that in adults the subglottis is stenosed, and when you are going to say in pediatric population that your basically in neonate and premature, basically most of the population which are neonate and infants, you have some criteria for the diameter of this subglottis. So if the neonate is mature, a normal neonate, if the lumen is less than 4 millimeter in the subglottis, you will tell it as subglottic stenosis. If that neonate is premature, you can take this dimension as less than 3 millimeter, right? So a subglottic diameter of less than 4 millimeter full term is your stenosis. In premature, although this dimension changes to less than 3 millimeter. Okay. Now, if we discuss some questions, so this is again a picture showing you a healthy subglottis where you can appreciate the lumen, and a stenotic or subglottic stenotic glottis. Okay. Now, can you fetch me the diagnosis of this picture where in the laryngeal inlet, or you can say over the supraglottis part and the glottis, there are some visible lesions there. What lesions these can be? So already you can see something is mentioned here. So these are your papillomatous lesion or laryngeal papillomatous, and very famous, they always ask this, is a newborn with recurrent respiratory distress presenting to your emergency department. So when on the examination you found a picture of this, so what it can be? So it can be your juvenile recurrent respiratory papillomatosis. Now this is again an important topic which we have to discuss in little detail, but if highlights you want to know, HPV 6 and 11 in treatment, there are certain alternative treatment like cidofovir, means these are the ones that have been already asked by your examiners. Interferons, which are some alternative treatment to these. But if you ask the ideal treatment for this, ideal treatment is either CO2 laser, means you have to debulk the disease or debulk these papilloma. So either you do it with CO2 laser or you debride it with micro debrider. So laryngeal micro debrider can also be used to remove this or debulk this so as to reduce the recurrence time. Okay, and one more thing is there is a role of giving nonavalent HPV vaccines. So even if your child is presenting with recurrent respiratory papillomatosis, you can give him or her the HPV vaccine. What they will do is they will increase the duration to which your patient will present to you after this CO2 laser or laryngeal microdebrider treatment. That means they will increase the interval of recurrence, these HPV vaccines, right? And the cause can be during childbirth. It can be this HPV vaccine can infect the child. So the cause can be during parturition or delivery, the child got infected and it resulted into juvenile recurrent respiratory papillomatosis. Now if we see some questions with the very basic, that is a stridor. So if I ask you this question which was asked in PGI, so that means multiple options will be right here. Yes, anatomic site of origin for stridor, and the options were your larynx, means multiple options can be right here. Bronchus, nasopharynx, bronchiole, trachea. So this question one cannot answer if he doesn't know the basis of a stridor and how it originates. So if I give you some time to answer me, a PGI type question means multiple options will be right. When you will say that stridor is present, when the obstruction will be in the larynx, bronchus, nasopharynx, bronchiole or trachea. So you can answer me like A, B, C, D, E. And if I tell you the answer is A, B and D. Now, why not nasopharynx? Because the obstruction in nasopharynx, the sound that will be produced will be called stertor, means not stridor but something different term called stertor, that is stertor. So this type of sound will be produced when there is obstruction at anatomical locations like nose, nasopharynx. oropharynx, right? Now, when stridor is produced, when there is obstruction at the level of larynx, means it has to be starting from the level of larynx and below. Now, below up to what? So, larynx, trachea, primary and secondary bronchus. So, note that up till bronchus, you will get your stridor. Now, what is if obstruction is below the bronchus, below the secondary bronchus? That means if there is obstruction at tertiary bronchi or in the bronchioles, then what sound you will get? So you will get wheeze in your patient. So if there is obstruction at the level of tertiary bronchi or at the level of bronchioles, so see how basic is this, and they had asked you a question from this, right? So here your basic for stutter, stridor and wheeze is clear, right? Now a similar way, one another question based upon this only. Stridor is caused by all except, so I'll be little fast here because it is sort of same question, but we'll see how many of you got the thing. Stridor is caused by all except, options are hypocalcemia. So don't think it is easy. Again, it is an applied one. Asthma, epiglottitis and laryngeal tumor. So what do you think, in which one your stridor won't be produced? And the concept, so as I told, they will be asking questions which will be applied. So now you know the concept. Just you need to know key in all these conditions at what level your obstruction is occurring. Stridor is just a sound that is produced when there is obstruction in nose, nasopharynx or oropharynx. So it's a different sound than stridor. Stridor is something which you will hear when there is obstruction in the larynx, trachea, primary bronchi or secondary bronchi, up to that. Okay, so here you have to find key at what level. Now if you see by answer of exclusion, in larynx if there is obstruction, it will cause stridor. So this cannot be your answer because here the examiner is asking except. Epiglottitis, again a part of larynx, so stridor will be present. Asthma. Now in asthma, if you notice, mostly the asthma involves the small tertiary bronchi. So there is obstruction at the level of small tertiary bronchi in asthma, and this lead to production of wheeze, right? So mostly the answer of exclusion here will be your asthma. Hypocalcemia might cause tetany, so contraction of these muscles, and others might cause decreased lumen in the larynx and might cause stridor. But in asthma, you definitely know that there is obstruction or contraction at the level of a small tertiary bronchi, and thus wheeze will be produced, not stridor. So in the emergency department, you have to assess whether your patient is with stridor or not. So stridor is something which is created when there is almost above than 50% obstruction. So almost when the laryngeal inlet is getting blocked, this type of inspiratory sounds are produced, right? Now if I see some more question, and we'll discuss in detail in that unacademy section, because if I discuss this in too detail here, it will be too much for you. So you will have some mindset. I'll share the link, and then in that app we'll see. Now I'm giving you a clinical scenario. I'm not going to write the question but only the answer so as to make it little fast. Question is, a 1 year old, or you can say not 1 year but 1 day old child presented with weak cry since birth with biphasic stridor. Now, the things you need to note is there is a stridor since birth which is biphasic. Incomplete canalization was considered. Most common site of defect would be, another thing that they have mentioned is incomplete canalization, and they had asked you what is the site. So again it involves some concept, and we just see the options. A is your supraglottis, so it will become easy once you know the concept. Supraglottis, glottis, trachea and hypopharynx. Now to answer this, you must understand when the stridor is biphasic, when the stridor is inspiratory, when the stridor is expiratory. So can anybody of you tell me when you will get an inspiratory stridor? Your inspiratory stridor, okay, I'll tell you the columns. Inspiratory stridor, biphasic stridor, that means when it is present in both inspiratory and expiratory. Then expiratory stridor. So inspiratory will be seen in any lesion which is supraglottic. So supraglottic obstruction, if it is there, you will see inspiratory. Another thing is in glottis also. Why glottis? Because you see glottis shows a biphasic type of stridor, because at the level of vocal cord it will produce stridor in both inspiration and expiration. Your subglottis also shows biphasic type of stridor. Now when you will get expiratory stridor, this is something that will help you to solve some more questions related to it. So expiratory stridor you will get when there is obstruction in intrathoracic trachea, when there is obstruction in primary and secondary bronchiole. So when these, so we had already discussed that up to secondary bronchiole you will get a stridor, and this obstruction in intrathoracic trachea, primary, secondary bronchiole will produce you a expiratory stridor. Inspiratory will be in supraglottic and glottis. Now glottis will be also present in expiratory because it is basically biphasic. So biphasic is glottis and subglottis. Now moving back to this question, if we see how we can get the answer. So you all said the answer here is glottis, right? How you got glottis? Because if you see the child in glottis, one more thing will be mentioned in the question is the baby has means cry, the feeble cry, because the voice is also affected when there is any lesion or obstruction at the glottis. So cry will also be feeble and affected with stridor, and that will be biphasic, right? So in glottic pathologies, the cry will not be normal and stridor will be biphasic, like in this case. Then they had mentioned incomplete canalization, that means child is having something called glottic web. The image that we had seen is glottic web. So like this, there are some more questions that I want to discuss, but for now, and incomplete canalization means, if you see this diagram, okay, yeah, so if you see this diagram, canalization means laryngeal lumen in the embryology, when this laryngeal inlet is getting formed, when the vocal fold is getting formed initially, whole of this is obscured. So for a lumen to get formed, for a complete lumen to get formed, you need canalization. Now in conditions when this canalization is incomplete, like here, where the canalization is incomplete, in anterior part you can still see a thin white membrane, then it will lead to a condition called laryngeal web or glottic web, right? So this is the not laryngomalacia. So this is another common malformation, you can say congenital malformation, that you would see in a child who is presenting to you with respiratory distress and all, right? So we'll discuss things in little more detail, we'll plan a better session, we'll post you all. Only one request is you can just WhatsApp me at my number so that I can add you whenever I take any class and give you a notification. And I'm also planning to make a better course for revision so that you can revise, because at the end when you reach your last 1 month, there is so much to read, so much to revise, and so much of tension and peer pressure that builds up. So to clear this, I had formed a course last year which had helped many of your seniors. So I'm trying to make a better version of it and will intimate you as the things progress so that you can early enroll and get the benefit. So revising those topics, revising those stuff will only require your 15 to 20 minutes a day. That means whenever you are having your tea break, whenever you are having a break and you are walking somewhere to lighten you up, you can just watch that video and get some important insights, because getting to the exam is knowing the most common, the most important, the high yield topic. If you ask me, you cannot master all the 19 subjects in the duration of 6 months to 1 year and or even 2 years, because if you see, all the 19 subjects are a specialty subject, right? If you consider ENT, you need to study ENT for more 3 years, get your MS degree, and then even MCH, and the professors, if you see, they keep on reading, so there is no end to the knowledge. But our main motive, our main focus is to clear this exam in this 6 to 8 months. So we need to be little smart, we need to be little selective. I'm not saying that you don't study all of them, I'm saying studying all the 19 subjects is important, and to make it feasible you need to study first the most high yield things, which we as teachers most of the time, seeing the papers, seeing the trends for so long, get an idea. And the same thing I will convey through my course, and I will keep everything so cheap that so that every one of you can get that, because my main motive will be to get you or to make you feel the benefit of the things through my experience. So it will be more of giving. The intention will be to be a part of your success journey so that you achieve the things you are working for. So I'll end this session for today. My WhatsApp number, if you don't know, I'll post it in the comment section. You can go from there. There's one Telegram group also, you can join there. Until then, keep up the hustle, keep up studying, and I know you are putting lot more effort in this difficult time. Salute to all your efforts, and I hope that you get the things that you are working for. So this is Dr. Shivam, hoping you a healthy and happy future ahead. We'll end this session for today. Good night.